Dr. Elizabeth Dineen, it's so good to have you here with me. Welcome to Reboot with Dr. Arasi Marin. So I know you're a sports cardiologist. Can you tell me a little bit about how you got into the space? Because you hear about interventional cardiology, electrophysiology, but sports cardiology is very exciting. So tell me a little bit more about it, please.
Absolutely. So happy to be here. Thank you for the invitation. So sports cardiology, I found out about as a field when I was an internal medicine resident, and it's only been really acknowledged sort of by the ACC as its own subspecialty for about 10 or so years, maybe going on 15. Not that it's extremely novel. Certainly athletics and cardiovascular care of athletes predates sort of this being recognized as a field. But sort of the athletic changes of the heart, different risk factors, maybe different management strategies for these athletes and screenings has called attention to there being an important need for research and specialists, not just sort of a general sports cardiologist, but all different varieties of cardiology. So usually a lot of sports cardiologists will have imagers and interventionalists and electrophysiologists and geneticists and everyone else as part of their team. But like a lot of people in this field, I have a personal passion for exercise, grew up running quite a bit, and really enjoyed understanding the physiology of exercise. And so when I learned that I could blend that together and help take care of athletes and guide them along their path, it seemed to be sort of a no-brainer for me. There's not yet a specific pathway, but there's been documents that have come out to say what should be part of a sports cardiology curriculum. And so I think probably in the coming years, not only are there some fellowships that exist, subspecialty fellowships, but probably more will be created and potentially board examinations and things of that nature.
Absolutely. So, do you work just with athletes at this time, or how is your practice work?
I do not. So I don't think hardly any sports cardiologists work just 100% with athletes. Usually there's sort of a focus on something. And in my case, it's prevention and echo and medical education. But the percentage of sort of sports cardiology specific clinic and research is increasing. You can certainly talk about exercise and the importance of exercise with nearly any patient. And that's at the pinnacle of sort of lifestyle conversations that we have with trying to prevent heart disease for patients and trying to get people back into physical activity after an MI or with heart failure, or a new diagnosis or a new family risk factor. But it's really quite fun to see people across the spectrum of age, and also recreational athletes, competitive athletes, sort of everyone who's putting kind of a high premium on exercise and sport. I think that's what we're all striving to kind of get people to and to take care of as well.
That's absolutely true, right? Like, even forget the competitive athleticism, that a lot of us are trying to be better, and hence the name Reboot for this podcast. So, my audience, I primarily think of people who are in the cusp of wanting to live better or wanting to make a change in their life for a healthier living. If they are going to start an exercise program, there's always this disclaimer, right? Please can talk to your doctor, or please talk to your cardiologist. Are there any testing you do, or how would you tell them? What advice would you give them?
Yeah, so that's a great question. I don't necessarily think every single person starting an exercise regimen needs to see a cardiologist, but perhaps they'd find their way here if they have certain risk factors for heart disease. There have been some studies showing that masters athletes are those who are over the age of 35, that they have more of the sudden cardiac death and events due to atherosclerotic coronary artery disease during the demands of higher intensity exercise. So kind of working backwards from that, there are a lot of people who push for and advocate for kind of screening certain populations to make sure they're kind of fit and maybe don't have subclinical atherosclerosis that isn't controlled or other risk factors before embarking on sort of a higher intensity exercise program. And so certain testing that can be done, and it's not a one size fits all. It needs to be individualized. Are people having symptoms? Do they have risk factors? But even we can get a lot of information from a regular treadmill exercise stress test with the ECG. And certainly we can improve sensitivity by adding the echocardiogram in certain populations, as you know. And then also we can offer the cardiopulmonary exercise test, which will kind of dive a little deeper into the components of lung, heart, and muscle contributions to exercise. And a lot of people think of this as the VO2 Max test and kind of looking at their cardiorespiratory fitness.
Okay, so you mentioned CPET. So can you explain what it involves and what are the components of it, and how do we make sense of where each individual would fall with the results of it?
Yeah, great question. So we get a lot of data from the CPET, or the cardiopulmonary exercise test. In our lab specifically, we do this test very closely and actually orchestrated by one of our exercise physiology PhDs and one of our exercise physiologists. So it depends on which lab you're going to, but that's how we do it in our sports cardiology lab alongside a sports cardiologist. We also have a clinical CPET lab run by our pulmonary group, primarily with input from cardiology. So I should say that it's, sort of not every lab will have different variations on how they're doing the test. And we can do this test on many different modalities. We try and match it to whatever the favored exercise is for the person who's being tested. So if someone's a runner, we try and test them on a treadmill. If they're a cyclist, maybe a bike. Some labs will have the rowing erg and ergometer, and others will have other devices that can be tested on. But at any rate, we try and match that, because some people were trying to replicate symptoms they might have during exercise and try to recreate that. The test is, I think, importantly to know why it's ordered. Sometimes we look at prognosis. When we think about heart transplant patients, I think this was where it's most commonly used initially, looking at the VO2 max and other parameters. We can look at sort of the progress or the change that people might have with implementing some sort of intervention or exercise regimen, for example. So we might test someone a couple months later and see how they do. We can help to establish a diagnosis if they're having certain symptoms, shortness of breath, chest pain. Are they having a cardiac or a pulmonary limitation? Well, we can often see signals of that from the data that comes out of the test. And can hopefully risk stratify as well.
I have, sorry, I didn't.
Oh, go ahead.
Go ahead. What were you about to say?
Oh, just there's so many different variables that come out of this test. And so it would be hard without pictures to show all the charts and graphs and things like that. But there's so many different parameters that you can look at for the cardiovascular health. Not only just obviously the heart rate and the blood pressure and the ECG tracings, but the oxygen consumption, aerobic efficiency, things like that. And then from a pulmonary standpoint, we can check spirometry, breathing reserve, other parameters there. And then we can also look at gas exchange efficiency. So we don't always come out of the test with a diagnosis, but it will often point us in a certain direction to do more testing.
So you talked about it seems like a very comprehensive test, right? Like just the number of things you talked about here. Do they like I have a referral here in Charleston, South Carolina, who does the CPET. They are a primary care practice, but they are more of a longevity practice, and they send patients who have abnormal CPETs, and I've sent so many of them to surgeries and put stents in them and things like that. And one of the things I found it interesting was it actually gives a cutoff heart rate, cardiac myocardial dysfunction, and noted at this particular heart rate. Can you kind of talk about that little piece for now?
Oh, I see. Okay, fair enough. Yes. So let me think about this. So from the data that we get, it can be organized so many different ways. And one is to give almost heart rate exercise zones. And so based on where we see lactate thresholds, where we think critical power might be happening. As part of our lab, our exercise physiology team, they put together a nice report for patients to kind of guide an exercise prescription. And for example, if someone's having myocardial ischemia at a certain heart rate, we often will tell them, and we can tell that based on some of the different O2 pulse curves and when the lactate threshold is happening. Then we can work backwards and say, oh, what was the heart rate at that time point? And say, okay, well, let's work out below that threshold so that we're not hopefully causing ischemia. But
Okay.
it becomes complicated if someone has those factors and then they want to go to altitude, for example, where some of these curves might be thrown off and they might become ischemic sooner, with less oxygen, ambient oxygen. So we do give some of these heart rate zones, and based on some of those metrics that we're able to see, based on the ECG tracing and some of the O2 pulse, stroke volume surrogates, and other things like that.
So, apart from your transplant patients, who are the prime candidates to get this test? Who should be asking for the CPET test? Is it something you decide or the primary care decides? How does the decision get made?
Yeah, great question. And so yes, medically, a lot of times it is always it's part of guidelines for a lot of congenital heart patients, heart transplant. There's hard metrics that are looked at to say when someone might qualify for certain therapies or treatments, like you mentioned. Less robust indications, but a lot of times why we're testing is because of symptoms. So, there's good evidence to kind of look at patients who might have shortness of breath or chest pain, and we try to delineate, is it from the lungs? Is it from the heart? Is it a muscle limitation? And so that's a primary reason to order the cardiopulmonary exercise test versus a
A
traditional just
nuclear
regular
stress test.
stress test. And other people, although potentially not covered by insurance, like to know how they're doing from sort of an exercise improvement standpoint. Like if they're trying to PR at a race or improve their exercise parameters and what they're tracking, they might come back in and get this CPET test performed. But a lot of times we're doing this either medically, like you mentioned, to kind of maybe draw out symptoms or see what the VO2 max is and exercise limitations in people who might not be so active, like heart failure or certain other patients, or to evaluate for the symptoms and try to delineate that. And it could be decided by primary or sports medicine or cardiology or any of the above
Yeah.
others as well.
So, another interesting topic you just briefly mentioned is the VO2 max. And there's a lot of interest in longevity and using VO2 max as a measure of longevity. Can you kind of describe what is the cutoff? Is there a general cutoff or how does that work?
Yeah, good question. So the VO2 max is thought to be sort of the maximal oxygen uptake or the maximal aerobic power the amount of oxygen that your body can uptake or use during exercise. And so there's a lot of things that can go into that. Thinking about the Fick equation and what is your hemoglobin and oxygen carrying capacity and efficiency and uncoupling at the mitochondrial level, generating energy. So all of that can kind of go into the VO2. And usually the standard of predicted VO2 max is based on many different studies that have been done to try and normalize data to say, okay, based on your age, your sex, ethnicity, and body size, someone with those characteristics should have a VO2 max around this metric. Now,
Okay.
so we do see though that those equations fall apart if you're testing people that weren't part of the validation equations and people that were studied to actually come up with those standards. So, for example, if we have elite competitive endurance athletes coming in, we almost expect them to be at 140 or 150% of predicted VO2 max. And so what becomes challenging to interpret in that situation is if you don't have a baseline test on them, and then they come in with symptoms and say they get 110% of predicted VO2 max, but they say, listen, I'm not performing well, I'm short of breath. It could be that they actually do have a limitation for them, even though they're sort of outperforming the standard.
Okay.
So you have
That's
to
interesting.
interpret it within the context of the patient that you're or the athlete that you're working with.
So for normal people, I mean, and there's this opinion that high VO2 max is associated with longevity, and low VO2 max is kind of it's a poor predictor of longevity. Forget the athletes. Let's put aside athletes. For normal, regular people, you said about 140% is for athletes. For normal people, where should our VO2 max be?
So it's all based on age, sex, gender,
Okay.
age, sex, ethnicity, and body
Mm-hmm.
size. So there's not a
Okay.
specific number for every single. You can't just give kind of a blanket number because it's based on all of that information.
That's interesting. So there's no cutoff. There's no like our ejection fraction, 55% is now. So it's not like that. So it's so individualized for each person.
Yeah, and there's ranges for what you might expect if you know what someone's training or baseline activity level is. And there are cutoffs on the lower end for heart transplant.
Okay.
Um,
Huh.
but there's not, to my knowledge, a specific number that you have to get over per se to just apply that just across the
As a
population.
longevity. Okay, okay, interesting. So, the reason why I'm kind of pushing you is there's so many podcasts, so much information on VO2 max. Go get your VO2 max measured, and that tells you how long you're going to live. And there's all these extraneous information about VO2 max, and that's why I'm like trying to tease out: does everyone right now need to go find a CPET center and get their VO2 max and track that or
Mm.
so unless you're a trained athlete and having trouble during training, there's not necessarily an indication. Or if you have a illness or a sickness, like you're planning to get a liver transplant or a kidney transplant, then maybe there might be an indication. Otherwise, if you're functioning normally, you don't need to keep chasing this metric. Am I correct?
Yeah, you do. I don't think you need to chase it necessarily, but I think you could extrapolate that and say when people have better cardiorespiratory fitness, we know they have less cardiovascular um, death and less cardiovascular disease. So if you translate that, if you have a higher VO2 max, you have a higher cardiorespiratory fitness, and for the most part, unless you're an extreme exerciser, more exercise is generally better, except for potentially very limited situations if you're told to restrict your exercise. But if we think about those mortality curves, we start to see a huge benefit if we have 2.5 hours a week and on average of moderate intensity aerobic exercise. But we see even more bang for our buck if we do higher intensity interval training. So you can do 75 minutes a week. But even more than that, you continue to see improved cardiovascular outcomes. So I think you could then, and we know, yes, the better your VO2 max, probably the better your outcomes. But I don't know that it has to be sort of, I don't know that we have data to say you need a CPET every year for a preventive standpoint yet.
Okay. So I'm going to use your own answer for the next question. You talked about 150 minutes of exercise, high intensity training. Is there something called too much of a good thing when it comes to exercise? How much is too much?
I think the studies that are out there, you really have to be doing a lot of exercise to hours and hours at high intensity for years to see some of these longer term potential impacts of endurance athletics. There have been studies that say there's more atrial fibrillation. We know there's physiologic kind of changes that happen with the heart, but some are talking about sort of ARVC-like kind of remodeling of the right ventricle with long-term endurance athletes, and some can have sort of an arrhythmogenic component as well. There's been debate about myocardial fibrosis. There's studies that show that there's more coronary artery plaque or calcification in people who are doing more endurance sports for longer. But going back to our VO2 max and cardiorespiratory fitness, when stratified across their fitness levels, even people with high coronary calcium, the higher the fitness level, the less cardiovascular poor outcomes that they had. So the exercise is still protective in many ways, even though we're finding some of these other things. So I think, like many things, probably more data is needed.
So, you had a very interesting paper in your publication list about exercise and pre-diabetes and diabetes. Can you talk a little bit of what does exercise do to pre-diabetes patient or a diabetic patient versus a pre-diabetic or a diabetic who does not exercise?
Yeah, and I think in that NHANES database that we looked at, there are certainly limitations to that retrospective study, but I think a big take-home message was that the higher the cardiorespiratory fitness, the less cardiovascular pathology or bad cardiovascular outcomes, no matter your sort of sugar or diabetes status. So truly exercise is medicine in many ways. And so that's why, kind of going back to the beginning, we can really incorporate sports cardiology or exercise discussions, and should, if, a lot of people don't take the time to really engage with how much and what type of exercise and for how long, or why are you not exercising. And so just getting people moving, I think, is so important in so many cases.
You also had another interesting paper on gender differences in exercise. Can you touch upon that?
Yes, so an area that needs a lot of prospective, larger scale studies. But we had we had the paper out there that, male athletes do typically outperform females starting around puberty. And the thought is that it's related a lot to hormones, specifically testosterone in males. And so with some of the data that we know, females tend to have a lower peak oxygen uptake, even when sort of accounting for a smaller body size, lower stroke volume and hemoglobin, and lower muscle mass. But I will say even though females haven't been as represented in some of these athletic studies in the past, women seem to have less AFib, less sudden cardiac arrest and death, less coronary calcification, less myocardial fibrosis. So there's a lot of hypotheses out there about their remodeling and implications of hormone status. We don't really know probably enough to make definitive comments about it, but there's definitely some different signals that are seen.
We're almost coming to time. So one question. This is a debate. It's been going on for several times, right? I kind of know what you're going to answer, but I'm going to still ask you anyway. You're a runner. So do you think we should do more cardio or more strength training?
My vote would be for cardio. From the aerobic cardiovascular exercise, moderate intensity at least. Strength training is important, but my vote for heart health would be for the cardio.
Awesome. If someone's had an MI or a heart attack, right, and they want to start back onto exercise, especially an athlete or someone who's been running and who's been active, and for whatever reason, strong family history, has a heart attack, can they go back and exercise to the same extent after they've had a stent or have had surgery?
Yeah, so that's a great
Hopefully
question.
the intervention has done a good job with the stent.
That's a great question. And there will be an updated scientific statement coming out hopefully at the end of this year or early next, speaking to this question. But the short answer is probably yes, but it depends on all of the different risk factors we think about. So I think often athletes are pushed in a bucket to say, or someone who's just active, oh, you know how to exercise, you don't need cardiac rehab or statins or, and so I think it's just equally important to be pushing these guideline directed therapies, no matter who the patient is, when they've had an event. So making sure all the risk factors are as optimized as possible, blood pressure, et cetera, go through cardiac rehab, and then make sure that the heart function is normal, no major wall motion abnormalities, getting people on a maximum treadmill test, making sure there's no major red flags from a rhythm standpoint or a symptom standpoint. So I think it's not a simple yes, but a lot of people can get back to having fairly active lifestyles afterwards. It just takes time. And if they can just hold the reins a little bit and allow for more of the plaque stabilization and some of these therapies to take effect, I think some people think it's a little bit better if they wait just more than just 3 months potentially, but it's all individualized.
Fine. I'll let you go with the last question. Statin has been getting a lot of bad press lately. It causes diabetes, everything. And people just blame everything on statins. And then there's conspiracy theories that we are just prescribing statins and making people sick so that we doctors make money or the pharma companies make money. What do you think about statins?
So generally, I think statins are really helpful to be part of the toolkit for prevention. I think they're still, for most people, kind of a number one medication to try for numerous reasons and years of data. But there are people that have side effects. So I think, if having the patience and time to talk to individual patients about what their goals of care are, what their fears might be about certain pharmaceuticals, if they do have side effects, can the regimen be changed so that it's a less potent dose or less potent statin? Can it be every other day? And usually these types of things, as you know, can just take months and more to kind of get on the right regimen. And some patients come in and say, they felt like they were just given a pill and they're told this is the only option, this is the only dose, and you need to take it or you're non-compliant. And so I think we know better than that, that there's so many options of statins alone. And good news is that if people are truly resistant or have side effects, we've got other pills and injections and lifestyle counseling and other things like that that we can use.
All right. Dr. Dineen, thank you so much. I hope our audience find this conversation interesting. And I hope people understand that VO2 max is not a must for every person, but instead just exercising, cardio, as you had recommended, is probably the better way to go than, trying to find metrics that may or may not make a difference in each person's life. Thank you so much for talking to me today.
Thank you so much.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.